Well, let's see. I was employed in 1995 by the Los Angeles County Department of Health Services, and that was in a cooperative project with the Centers for Disease Control and Prevention, CDC. And we were to study the effect of the chickenpox vaccine on this Antelope Valley population, which had roughly a population of 300,000. We were one of 3 sites in the nation selected to conduct active surveillance, which means we would identify all schools, hospitals, medical care, health care centers that would report cases of chickenpox, and we would actively obtain those each month. So what happened in the course of time, we initially started monitoring only chickenpox, but there were some nurses in the schools that were saying for the first time they were hearing cases of children with shingles, or herpes zoster is the technical name. And so just before our grant was renewed in year 2000, roughly 5 years later, what we did was put in a proposal to monitor both chickenpox and shingles because it was no more difficulty. We already had it set up to collect the chickenpox cases, and it was trivial to add shingles to the data. Within a year or so, I found abnormally high incidence rates of shingles among children who were not vaccinated. Also, reports among adults seem to be increasing in the community. I participated with the CDC in the publication of papers that showed the 80% decrease in chickenpox from 1995 to around the year 2000. But there was specifically no request for data dealing with the shingles and its incidence rates.
So, and I understand the connection, but if you could really explain the connection between chickenpox and shingles and why we even should have been looking, or why they should have wanted the data.
Right.
Shingles.
Initially we should have been monitoring both diseases, but the plan was only to monitor the chickenpox vaccine. Shingles is a disease, a secondary disease. Once you've had the chickenpox, you can reactivate the same varicella zoster virus as shingles. That's normally on one side of the body in what is called a dermatome, a specific region, and it's the second manifestation after you've had chickenpox. Normally, older adults get shingles many, many years after their chickenpox initial case. Adults continue to be boosted year by year by cases of chickenpox in the community. And so once you're boosted, your body is reminded that you once had chickenpox and you build up an immunity again. And when that immunity wanes, such that you're no longer have these exogenous or outside exposures to children with chickenpox, then you will break out in shingles.
You said that you were noticing shingles in children who had not even been vaccinated against chickenpox.
Right, but they had had the natural chickenpox disease.
Oh, I see. But then they were, so do you think it was because they were re-exposed to a genetically engineered chickenpox virus from the vaccine? What was going on there?
Well, as the vaccine became more widespread, and by year 2000, 50% of children aged less than 10 years old had been vaccinated, the boosting from children in the community with natural chickenpox was severely decreased because so many children had been vaccinated. So the young children that had had natural chickenpox, which is called wild-type chickenpox, no longer were receiving those exogenous or outside exposures. So they were reactivating with shingles.
And what about the children who had received the vaccine? Were they getting shingles? Were they coming down with shingles as well?
Vaccinated children were reported as having shingles, but it was less than those who had the natural disease because the vaccine was an attenuated OCA or vaccine strain of the virus. And so once you're vaccinated, you get a recent boost, so you're unlikely to reactivate with shingles. Still a small number reactivated with shingles.
And so what happened with this information? What was going on? I know that there was some issue with the CDC not wanting you to publish your findings.
Well, I was the sole research analyst for our group in the Antelope Valley area. We operated out of High Desert Hospital. So I had access to all the information. I had written all the programs of analysis and that were used in the summaries to CDC. And so I was encouraged to write whatever was of publication quality material to promote the varicella vaccine and vaccination in general. When it came to shingles rates, the CDC, along with the local supervisors out of High Desert Hospital or the LA County Department of Health Services, did not want me to really investigate the shingles aspect.
Because it would look bad for the vaccine? Or?
Because that was considered a deleterious or negative effect of vaccine, and it could possibly influence vaccination rates.
What did you think about that?
I wanted to be an honest researcher and look into all avenues that were affected. So I, heard what they said, but I still kept an active study of the data that was coming in to try to explain why are shingles increasing. And so then I looked at different medical journal papers, and I found one dating back to 1965. Dr. Hope Simpson had initially made a suggestion that the rates of shingles in the different age groups were due to the association with children with chickenpox. So adults who rarely have contact had very high rates of shingles. Adults with children had lower rates of shingles than parents who had already raised children and the children had left. There were also papers on physicians that saw children regularly in their practice. They had 1/8 the shingles incidence rate of the normal population because they were getting boosted all the time. So then I had the biological mechanism that explained why we were seeing an increase in shingles. The outside boosting effect from regular chickenpox, natural chickenpox, was declining due to children being vaccinated. They no longer manifested a contagious disease, and so as chickenpox exposures decline, shingles increased.
And shingles has a much greater morbidity and mortality rate than chickenpox.
Yes, that's a good point, because in healthcare terms, the costs to treat chickenpox are at 25% of the costs, and shingles is 75% of the costs. So even if you were to eliminate the 25% costs by eliminating chickenpox, now you have to deal with children and adults with natural chickenpox who had it as children, and now they are experiencing almost 100% increase in shingles. So that far offsets any savings, medical cost savings for chickenpox. Out of all the costs associated with chickenpox and shingles, 25% is our costs for chickenpox, 75% are costs for shingles. So if you eliminate chickenpox but shingles increases, then you've offset the benefit that you tried to achieve. Right, and just to re-emphasize, the chickenpox vaccine was not adopted based on any medical cost savings. So they had to analyze the time a parent was away from work to take care of their child. Once they did that and estimated it to be perhaps $360 million a year, then the vaccine was justified. But the cost to treat shingles well exceeded that. Also, The initial cost estimates were based on a vaccine cost of $35 per dose, and that one dose would provide lifetime immunity. What happened was the vaccine now is over $70 per dose. You needed a booster vaccine, and so those factors alone pushed the cost effectiveness to zero. I was included in several CDC publications, and then because I was encouraged, I decided I'd write more on some shingles studies, and I put together various other, at least 3 or 4 studies that I had proposed, and I was promised my local supervisors would read that, pass it on to the CDC, so it would go through a process, get approved for publication. But those just sat on a desk. And there was going to be no publication of any shingles data because it was, again, a deleterious finding. It wasn't cooperating with the positive vaccine. After serving 8 years, from 1995 till close to the end of 2002, I had to resign because I did not want to be part of research fraud. Actual studies that we had conducted, we were studying the susceptibility of chickenpox in the community, and we added questions that would also study shingles in the community. Well, the paper on susceptibility of chickenpox was accepted almost word for word as I had written it. The section on shingles and its incidence rate in the Antelope Valley was simply deleted with no explanation. Again, due to not wanting to be part of research fraud, I could no longer conduct research objectively. I wasn't even allowed to call 10 individuals who were reported to our offices as having shingles twice. Well, each vaccine needs to really be judged on its own merit. With the chickenpox vaccine, there have been many reports to VAERS, the Vaccine Adverse Event Reporting System, that document many adverse effects. And there's even recently been reported a death due to varicella or chickenpox vaccine. That particular vaccine has actually changed the whole structure of how immunity is gained within the communities of a country. And so at this particular time, it would take a large effort to actually stop and get the same protection naturally and for free from the outside boosting going back to children with regular chickenpox. No boosters would be needed because the annual epidemics of chickenpox, which is a mild disease, actually serve to boost for free the immunities in the adults. And so that natural immunity that is inherent to the disease has been lost at this point. Also, man only understands the fringes of these immune processes. So it's been reported, for example, that individuals that get fast-growing brain tumors called gliomas, they're individuals that never had chickenpox. So when you look at the outer structure of the virus of chickenpox, it's believed it may have an epitope or an outer structure that's similar to other antigens or other viruses. So by getting the chickenpox virus, you actually protect against other viruses that look or appear similar in their antigens.